get going here. So good afternoon, everyone. My name is Jason Worcester. I'm an internal medicine and addiction doc over at Boston Medical Center, also one of the MCSTAP consultants. So here today for our monthly webinar. Nice to see everybody, nice and prompt. So today's topic, or well, title, we'll get into a little more about what the topic will be, but today the topic is navigating opioid management and legacy patients, fresh eyes, safety, and planning for transition. So that is our task for today. I'm just going to do a few introductory slides on the MCSTAP program. I know many of you are usual customers, attendees, etc. So happy to see everyone, familiar faces and names. But for those who are new to MCSTAP, we are essentially a telephonic consultative service with lots of opportunities. Here is our number. We are open Monday through Friday, 9 to 5. And we offer a few things. We offer telephonic consultation for patients with pain or substance use disorder. We connect folks to resources. We also do a lot of coaching with our callers. And we really try to meet providers where they are, because we understand that you guys are busy. So we always available for you guys if you have questions about your patients. And in addition, we have a mentoring program we've had in place now for a couple of years, which has been really a positive experience, both for me as a mentor who's been mentoring some mentees, but also for our mentees who are getting hopefully a valuable experience from a longitudinal perspective. We also have a number of other kind of outreach opportunities to do with training programs, health centers, health systems, etc. But do reach out if you have any ways we could help you above and beyond today's monthly webinar. So we do have 10 consultants. Here are our mugshots. We are from all over the state, different kind of health system settings, but I say we're all really here motivated to work with the greater MCSTAP community and helping you manage your patients who are many times complicated, and that's what we're here for. Today's session actually doubles as for CME requirements, etc. So definitely take advantage of that. And then always feel the chicken on our website. We have a lot of resources that probably get underutilized. We have a number of kind of articles, summaries, etc. about different things that we offer. All right, so let's dive into the talk today. I'm joined by our MCSTAP Medical Director, Chris Shanahan, who will almost certainly pipe in over the course of the hour as we kind of discuss 3 cases. So our objectives for today's discussion, we're going to be talking about chronic pain, how to manage it, how it interfaces with patients' quality of life, functional status, social function, all the important things. And then always come back to safety, because safety is really critical as we think about legacy patients as well. I will say, feel free to jump in. We have I'm going to be presenting 3 real MCSTAP cases that I've actually got called about over the last couple of years, give or take. So feel free to jump in, ask clarifying questions, commentary, suggestions. Really want to make this as interactive as possible. And there is a chat too, which I will keep an eye on with my right eye. So taking a step back, so we're going to talk about legacy patients. So so just to kind of level set and get a definition here. So who are legacy patients? So legacy patients are basically those patients who've been on long-term opioids for many years. Kind of a simple definition, but obviously a very complex set of patients. I will say, for the majority of legacy patients, if you think about them, now that we're in 2026, are we kind of creating these, to say it another way, legacy patients? Would we be kind of applying the same principles of pain management that we were doing, 15, 20, 30 years ago? Probably not. I think we're a little bit more judicious now with opioids, although there's still clearly a need and use for opioids in our patients who are today at this point in time. But we are with these patients. They've been on opioids for many years. Things probably would have been handled differently 15, 20 years ago. But, we are now have to care for these patients. They've been on opioids for years. They have a lot of complex social issues many times, complex pain that's really difficult to manage. They're actually getting older, as we all do, right? So they're developing comorbidities that make the prescribing of opioids even more complicated. So they really require kind of this individual care. I know in other MCSTAP seminars of the last year or so, we've kind of brought up the 2022 CDC guidelines, which really brought kind of a fresh set of eyes on safe prescribing. However, a lot of these patients were, by definition, many of these patients were on opioids back in 2016 when the CDC guidelines came out with kind of more restrictive guidelines that created a lot of, to say no other, fear in many of our prescribers at the time. There was concerns about just government oversight, overprescribing, need to taper automatically in patients. So a lot of these patients kind of lived through that era. But the concept of an opioid orphan still exists. What's an opioid orphan? It's basically a patient who's been on long-term opioids that for whatever reason gets discontinued, dissuaded from coming to a practice. There's a lot of reasons what kind of scenarios where basically patients no longer have access to opioids for their chronic pain. And then subsequently, we know there's a lot of kind of risk of that. And many of these patients either don't have a primary care doc to go to because they're PCP retired. We're going to discuss a case like that today, but they're really stuck. And many times, unfortunately, because they're not able to get opioids in a safe manner, they are dependent, not necessarily addicted. Many times they are turning to street and unsafe kind of medication sources and drug sources. Okay. These patients have a lot of risks that are above and beyond just opioids for many different reasons. But those patients, because if they are discontinued, we worry about suicide risk, mental health crises, a whole slew of morbidity risks, overdose, and they're also utilizing ERs as well, because a lot of times they don't have any place to turn. And of course, many times the pursuit of their opioids may not always be direct either. It could be indirect, like repeated ER visits, et cetera. So they're complicated, and they are creating a strain on us as providers, because hopefully we will continue to treat them. But we are with them today, and we're going to go through some cases today. Actually, 3 legacy patients that some providers called in and asked questions about. So before I jump to the cases, any questions so far? Anything people need to clarify or thoughts? All right, I'm happy to jump into the first case. All right, so case 1. So this is a call I got maybe a couple of years ago. And this was a call from a primary care provider who called MCSTAP, and that's why we're here. And it was a patient with longstanding back pain. He'd had back pain going, 20 years, and not too not too rare, his PCP recently retired, and this PCP had been caring for this patient for 20 years, actually even going back to this accident back 20 years, and had been prescribing opioids for 20 plus years. This new PCP inherited this patient of the retired doc and was calling, really looking for advice, like how do I navigate this? What do I do? And it was the kind of the perfect call to MCSTAP. A little background, a little more of this particular 52-year-old male patient. He's had longstanding back pain, some depression, as well as hypertension. He'd been on oxycodone 20 Q6 hours, or 120 MMEs, also on sertraline for depression and some amlodipine for blood pressure. If I do recall, this oxycodone dose had been pretty consistent for many years. The patient was on disability, non-smoker, no admission to any illicit drug use, and also had a little bit of evaluation. He had an MRI of his spine about 11 years ago, got seen by orthopedics, and they felt there was nothing kind of surgical here and really recommended non-surgical management, physical therapy, pain medication, et cetera. So this was like 10, 11 years ago. The new PCP, who I think he was actually relatively new out of residency, did his due diligence, looked at the chart, but unfortunately there actually wasn't much in the chart. It was really kind of a poorly documented chart, which is unfortunately not uncommon. There was no urine drug screens. It, again, looked like the oxycodone dose had been stable for the last 5 years. No major increases or decreases. The mass PAT looked okay. No discordance there. And the patient seemed to be relatively adherent to his outpatient visits, coming in every 3 or 4 months or so. Okay. And then I had spoken to this new PCP just after the first visit. So many times we actually get calls before the first visit, like, how do I approach this visit? But this PCP had actually already seen the patient once. Of course, a new, a new visit for both the PCP as well from the patient perspective as well. And what I got from the story is that the patient really had no new complaints. The chronic pain was there. It hadn't changed now for many years. Oxycodone helps them with some daily activities. There was some depression that was happening. And the PCP just broached the topic of, what do you want to do with your oxycodone? You've been on this for 20 years. And the patient stated that he definitely couldn't stop it and that he would actually like to go up on the dose for no other reason that his pain was still there. Although some functional improvement, some improvement in the overall pain level, it was still present. So the patient said, hey, maybe I should go up on the dose just because I'm still in pain. Like, kind of not unreasonable thinking, right, from a patient perspective. So that's the case. I don't know if people have any questions or things I can clarify as best I can, having not seen the patient personally or whatnot. I will say the tone of the call with this caller was that he was, how would I describe it? Definitely nervous, definitely feeling a little bit kind of, maybe, I don't know if overwhelmed is the term, just because he was a relatively new provider, kind of inheriting this panel of patients. This was one of many, and just was just kind of like, what do I do here? It was kind of where this caller was calling from. So definitely some concerns and kind of like having, I would say, an emotional response to the situation, saying, okay, I'm nervous. This patient's been on these meds. I'm now kind of, I think in so many words, he was like, oh, I'm getting this, taking on this risk of this patient, right? So suddenly this patient's been on oxycodone for many years. Again, the other thing he was maybe not upset about, but a little concerned about is that there wasn't great documentation in the chart, right? It was just kind of patient seen, having pain, refill the oxycodone. It was like this kind of repeated notes that all kind of looked the same. I think that's the way he kind of described it. So not a lot of insight he could glean from this now retired PCP. Chris, you have a question? Yeah.
It's not a question, it's just a comment, which I forgot. So it'll come back to me.
All right. So Sarah Lennox, Dr. Lennox, what's your you got?
Well, I think it's not an uncommon problem, and the main thing that from my practice experience that was helpful was to get to know who the patient was. What's their family situation? What are they able to do in their life? What do they enjoy? How else is this affecting them? And to sort of explain that guidelines have changed. There are some requirements, but we're not going to go into this with a major shift at this point in time. We're going to take it one step at a time and see what's going to work best for you. And I'm going to get some help from some experts about it and, go from there.
Right. Yeah. So good points. I think part of like what I try to do at this visit or this call with this new PCP was that there's like a couple questions, like quick questions, like, are there any immediate safety concerns? Like, is this, if you just kind of kept going with these prescriptions, is there any major red flags? And the other is like you mentioned, Sarah, like the engagement with the patient, right? You got to, like, this guy's been, whatever he's been doing for 20 years, or at least 5 years, being on the same dose. So whether it's working or not, like, he's been coasting, to say it another way, for 5 years. And that, when I talk with the caller, I'm like, you don't necessarily have to make any, again, major shifts or changes today. Just, first of all, like, from the patient perspective, right? You can imagine that the patient is going to have some angst here too, right? Some worry, right? Like, what's this new? Is there a new sheriff in town here? What's this new doc going to be doing? I've been working with this doctor for 20 years. We got to know each other. We had our system. We had our, and now there's this new doc coming in, raising questions about this medication that is going to create kind of potential worry from the patient too, right? So always looking at from the patient perspective is important too as well. So and right, as you said, Sarah, kind of understanding who is this, like, what's going on? Is there, what's going on with the patient? Is there ways we can improve his function with family, as you mentioned. So I think those are all very, very important pieces, I think. Learning more of the story as well. Chris, did you have a comment?
I remember what I was going to say, and it was pretty much what Sarah was talking about, but it's really that there is no emergency right now. Patient's been stable for years. There's no need to change anything. But what I like to do in this situation is I put the patient on, I'm going to say put them on notice, but what I say is, I'm a different doctor. I'm going to reevaluate you. We're going to try to see if we can make things better. And if there are things that are not working, we start to address them. But I don't make any changes. Often all I do is just refill the meds if they need a refill. And I try to convince them that we're going to work together and nothing's going to change quickly. So pretty much what everybody else has said.
Yeah, because there could be, just looking at this from like just a pain perspective, taking the emotion out of it. Like, this patient, he's been on short-acting opioids forever. Like, is there opportunity to switch him to long-acting opioids? Is there a way, kind of thinking about those things? Of course, did not recommend doing this on, I guess would be like the second visit, right? Because he had one visit, second visit. But just to kind of bring up like opportunities for improvement here that may actually continue to include opioids as well. So I think the other thing that came out of this that I saw, like thinking about the safety perspective, is that there wasn't great documentation in the chart. The monitoring wasn't great. I'm not saying that doing urine drug screens is going to solve everything for safe monitoring, but there are a couple of additional like steps that could be taking, like the concept of like discussing opioids again, resetting, like what's the patient's perspective. He's been on them for 20 years, but he is getting older. Is there, again, an ongoing kind of safety conversation, the concept of informed consent with the patient, right? Discussing opioids, discussing risks, benefits, concerns for, risks of dependency and becoming addicted, and all those things that get wrapped up into say prescribing. Did this previous doctor prescribe naloxone, right? Didn't see it on the med list, right? Is like some of the, I don't want to say the simple things, but the basic things that may not have been in place that, again, you want to, reinforce with the patient why you're thinking about these additional steps or safety and why it's important overall. Was this patient on 30-day supplies versus 28? The concept of, keeping people on a 4-week schedule versus 30, so there's not stacking or people running out on weekends, et cetera. Those little things that can be kind of things in place that may not have been in place before. So I think meeting the patient where they are, engaging with them, talking about revolving it around safety and opportunities for improvement and again, focusing on function, not the particular pain level, it can be helpful for this patient. I think the other suggestion I had is that many times, if we're thinking about treatment for chronic pain, many times we as providers, the patient get fixated on the opioids, right? Especially patients who've been on opioids forever, right? It wouldn't be unreasonable to take a step back and say, hey, I know you did physical therapy 10 years ago when you were seeing the orthopedist. Maybe there's an opportunity to revisit that again. Maybe you could get some benefit now that you're becoming more deconditioned, or however you want to kind of phrase it to the patient. They're thinking about other non-opioid modalities for treatment above and beyond what's on now, and not to forget those or making sure the patient isn't dismissing them because they've been so reliant on opiates at Sea Another Way, and they feel like that's the only thing that can be helpful. So this could be an opportunity to add on, bring up additional kind of non-opioid modalities as well. Okay. Other thoughts in this case? Other thoughts? I will say, from a systems perspective, if we go back to the case, like what went wrong here, this PCP was retiring, right? He knew he was retiring. Could there have been a better transition plan? Because this was actually an in-house transfer. This PCP was from the same practice, right? So thinking about like the transition plans is important too. Whether I'm in a practice at BMC, we have docs, pretty big practice. We have docs coming and going all the time, and it's not a surprise that if a provider has, say 15 patients on long-standing opioids, like how are you going to manage those patients? What's the transition plan? So it's not scrambling for that provider many times who is a new provider, right? Because it's more common for our newer providers out of residency taking on panels of patients versus those of people who have been practicing for a while. So it just puts an added stress to that new provider as well. So what are the opportunities for transition plans here, and bring that more of like a systems perspective? But we get calls like this all the time, and sometimes they're patients coming from other practices, which is probably even more stressful for providers, just because they even know less about the patient. At least this patient was kind of in-house and had a little bit more familiarity with at least, though scant, there was some documentation in the chart.
Jason, we have a question.
Yeah, sure. Yeah.
Yeah, I was thinking about the disability and somebody being on disability for 20 years and the idea of improving one's status can be challenging, because what are you as the new doctor saying, I want you to improve enough that you be off disability? It seems like there's a dimension there that also needs to be addressed.
Yeah, so so you're kind of asking the question, what are the functional goals of this patient, right? And what would be the functional goals of the provider, right? So yeah, it's a very reasonable question. That may be a concern of the patient too, right? Is this provider no longer going to support my disability or something, right? That could be another layer of concern too, where not knowing any of those details, that definitely could, because when you're talking to a patient about functional goals, that gets into his disability status and how that fits into his current lifestyle and current function or levels of activity at home versus what he can do for an employment. Those may or may not reconcile, right? So that is something that and maybe that is the goal of the patient. Maybe it is to get back to work, or maybe it isn't. It's hard to say. But good point. Yeah, very good kind of layer.
So that question is an excellent question, because it highlights the fact that this is a very complex transition. You have a complicated patient with a lot of chronic ongoing problems that has a lot of anxiety and a lot of concerns, and their whole life and their identity and their lifestyle is wrapped up in their diagnosis and these medications. And so transition to a new doc is challenging all of those assumptions, and it's probably terrifying for patients, as terrifying it is for the physician to pick that up, or the clinician to pick that up. So it's a fraught period of time. And so I guess going back to what was already discussed is trying to minimize the amount of change initially is important. And then the other thing that I would recommend is trying to allay people's fears and just say explicitly, we're not changing anything just yet. And our goal is to help you. It's not to necessarily just get rid of medications. So I think it's a sensitive period of time, that transition we could just say, oh, it's a legacy patient, they got a lot of stuff, but they're a special type of patient, and they require, a little bit of a soft touch. So.
Okay, let's actually move on to the next case. So case 2, this is another legacy patient. So this was another call that I got. So this is a 45-year-old male with shoulder pain. He developed shoulder pain at age 20, kind of similar story to the other one. Doing pretty well, best we can tell. And the PCP went out on a leave, actually a family-related leave for 3 or 4 months, and there was a covering provider. And the covering provider is the one who called me. It kind of set the stage here. And the reason the call came was that the covering provider, who was trying to do their best to treat for this, manage this patient for 3 or 4 months, hadn't had a urine drug screen and ordered a urine drug screen. And then the results, which we'll see in a bit, is the reason why the caller called me. So pretty stable patient. Again, he was 45 on opioids, not super high doses, 60 mm's of oxycodone on some non-steroidals, working at a desk job. He was a smoker, drinks a little bit, and a little bit of marijuana, no illicit drug use, and no prior misuse. As best, no kind of concerning behaviors. The best that this covering provider could glean from the chart. Again, covering for 3 or 4 months, and gets a urine drug screen, which hadn't been done in a couple of years, and kind of got this result. So the urine drug screen had positive cocaine, opioids, and negative for everything else except for oxycodone. And again, this patient is only on oxycodone. Okay. I'm happy to go through this, but any quick thoughts on this? Maybe interpreting the urine drug screen? You don't want to take a stab at? All right, so a couple thoughts here. So obviously we're seeing positive cocaine. So cocaine generally is cocaine. There's not a lot of things that can make a false positive cocaine. Again, this is a urine drug screen, so this is not kind of what we call a confirmatory test, but this basically says most likely this patient ingested cocaine in some way in the last 3 days. The urine drug screen actually looks for a metabolite of the cocaine called benzylcognine, but basically likely used cocaine in some form, whether intentionally or unintentionally, in the last 3 days or so. Positive oxycodone as expected. Patient is on oxycodone, so likely took ingested oxycodone in the last 3 days, but also positive for opiates as well. Now the positive opiate, again, oxycodone, is this expected? Not expected to see patients who are taking oxycodone to have positive opiates. So oxycodone is a semi-synthetic opioid, and there is some metabolism back, and people can become positive for opiates who are taking oxycodone. You tend to see it more in patients who are on higher doses, but I would say now the opiate could be coming from another source. So, morphine could be coming from heroin, some other kind of other opiate, but that, at least on first glance, could be coming from the oxycodone. So the other thing I would say about this urine drug screen is that there's no fentanyl in it, which is actually reassuring in the sense that the majority of people using illicit opioids right now, it's almost 100%, at least in the Massachusetts area, it's almost all fentanyl. So, and there's very little heroin available right now. So reassuring this patient is not using fentanyl. But it's also telling me that this person is also taking oxycodone. So he's, best we can tell, is taking oxycodone, presumably the oxycodone that we're prescribing, so that there is some use of oxycodone. I would think this maybe a little bit differently if this patient was positive for cocaine, but then negative for oxycodone, because that would raise the concern that this patient is actually not taking oxycodone, or taking oxycodone in an unsafe manner, maybe taking high doses up front when he gets the prescription and then running out. A lot of different scenarios. Again, a urine drug screen is one piece of the puzzle as you're trying to sort out what's really happening with this patient, right? But it's a concern, right? A random urine drug screen, having it positive cocaine. So there's some things that are kind of reassuring about this. Probably taking the oxycodone, probably not using fentanyl, at least in the last few days, but also at the same time, taking cocaine, which is generally, or using cocaine in some manner, making this kind of an unsafe situation. All right, any questions about that? All right. So the caller called MCSTAP, spoke to me, and said, what do I do? On the one hand, this PCP is coming back in a couple months. But the other hand, from the PCB's perspective is that as a PCB, they were saying that I had to kind of manage this. Like, what do I do? This patient's had a long-standing relationship with the PCP who's now out, but now I have this like additional piece of information, and kind of putting as the PC kind of felt they were kind of between a rock and a hard place. Like they wanted to not rock the boat too much, but they were also like presented with this potential unsafe urine drug screen result that may have a lot of possibilities of what's going on. All right. So we chatted, and we kind of talked about a few different things. So one, we helped kind of just think about the urine drug screen, what it means. And, I don't know, what would you guys do? What would you recommend to someone with this? Any thoughts? Chris, what would you do?
The question is, what's the first thing you do?
Yeah.
Talk to the patient. So I would just ask the patient, I would say, we did a urine drug screen. It shows that it shows the oxycodone that I'm prescribing. It also showed that there's some cocaine in urine. Can you tell me a little bit more about that? The statement, can you tell me a little bit more about that, is non-judgmental. It's very simple. And then you just wait. And it's a tough question to avoid. and then just listen. I have found that when I ask that question that way, the answers that I get are pretty accurate, and they surprise me sometimes because it's usually something that I wouldn't have thought. And it's usually never as bad as what I thought it was going to be. Occasionally it's, flat out, I'm using, or I'm selling or something, but very often it's not something that that we can deal with. Like it was a one-off. I went to a party, or sometimes I go to the party, but it's not a regular thing, or, I had a bad day. So in summary, just getting a story and asking and non-judgmentally, tell me what you think's going on here, is very, very helpful. The patients will start to try to, they'll try to give excuses at times, or they'll say, it couldn't possibly be me. So that the next thing I do, if the patient doesn't cop to it, the next thing I do is I don't argue with them at all. It's like, okay, I'm not going to find out what happened, but I say, okay, but this urine test is still positive, so we still have to deal with it. And then we talk about what needs to be done, almost as if they said, yes, I did it, but I never get them to say to do it because it's not worth it. And if you just keep moving on, it works. So anyway, I don't want to belabor it, but that's what I would do. I'd ask questions, and then if I start to run into things like, they're not able to be honest with me or straight with me, then I just move past it and I don't make an issue of it. I just start working on how can we prevent this from happening in the future, because it's important that it doesn't, because it's unsafe. So that's what I would do.
Yeah. I had, in speaking to the caller at the time, I said, when in doubt, talk to the patient, right? So, and I told him, to kind of ask about some things, because ask the patient, are you using, something that could have cocaine in it that you don't know, right? Whether that's
right. The patient may not even realize what they're doing.
Yeah, whether there's using marijuana from a non-dispensary source, or like, oh, I took a couple of my friends' oxycodone, or something.
I was visiting my aunt and I had a headache.
Yeah. So there's something unsafe, and they may not. And again, it could be unintentional as well. So we see that actually maybe with people who are using most of the things are like mixed with fentanyl now. So you'll see positive fentanyl tests come up on urine drug screen testing that fentanyl may be in things that they don't realize they're being exposed to. So just kind of had them think about that, as in that kind of open-ended questioning or suggestions, rather than, are you using cocaine or not? Like, tell me, like, what are you doing? Like, what's happening? So really trying to get a sense of where this cocaine could be coming from. So I don't have an answer, like, because this was a one-time call. But really gave that suggestion, again, as Chris said, to kind of talk to the patient.
But the key is they have to feel that regardless of what answer they say, it's okay. So no matter what they say, it's okay. I just want to know.
Right,
and
right.
If you can impart that to them, then you're doing it correctly.
So the next question, which is the primary reason why the patient called, is like, what do I do with the oxycodone prescription at the next visit? Or they were going to call him or something. I forget the scenario. Like they were just going to, when they connect with the patient again, because this patient will be due for an oxycodone prescription. It looks like they're taking it. And, you know, and I told, you know, kind of what the answer to that question is like, it depends a little bit. It kind of depends on what kind of information you get when you chat with the patient. But no matter what the scenario is, I think it really, or whatever kind of answer you get, the response has to be whatever we're doing next has to be proceeding with like increased safety. And that may be, you know, for example, you know, I said, you know, the patient says, I did actually smoke some marijuana and my friend gave it to me. Okay, so we think maybe that's the source. Who knows, right? The response to that may be maybe not necessarily like stop the oxycodone, you know, but to think about, hey, maybe we could actually let's keep it safe. Let's maybe do, instead of a 4-week supply, let's just do a week, and then and kind of see how that goes, right? So then you're kind of putting limits, you're still prescribing. You're not doing a forced taper. You're not stopping. You know, you're not necessarily making any particular changes in dosing. You're just kind of reducing the time course a little bit. Again, you're kind of allowing for a trial period.
Can I just mention one thing? And just to remember, because you're writing the scripts, they're coming back to you. So you have control. Sometimes you feel like, oh my God, if I write the script, what's going to happen? But they're going to come back to you and they're going to have to engage with you. Or if they don't, then you can't prescribe, obviously. So my point is, you have a little more control than you may think. Even though it sounds very scary, they do have to come back. And when they come back, that's when you can make additional changes if you need to. You can adjust.
Right. So that was probably that was going to be the tentative plan. But I said also, if you're finding something very unsafe, like he says, okay, yeah, I've been using a lot of cocaine, I'm using fentanyl now, I'm just like, things are uncontrolled. That actually is that's like a quick transition to treatment for a substance use disorder, right? That may be a different path than, you know, some additional monitoring, safety. And then the other thing I would say would be like documenting like everything you're thinking, right? Because part of some of this is like what was the provider's concerns? The provider's concerns were a few. One, like, I want to do the safe thing, I want to do the right thing, I want to keep this patient in care, but I also don't want to cause harm, and I also don't want to get in trouble. You know, so there was a lot of this kind of, the caller had a few different kind of, you know, appropriate concerns, and my response to all that was focus on safety and document everything that you're thinking and why you're doing it and what you're thinking. Okay. And I think that was kind of reassured this caller. You know, the other thing that can be helpful in these situations, not in this one because the caller didn't have access to, but speaking to the former PCP or the current PCP. Now the PCP was out, wasn't an option right now. But if you have an opportunity to kind of talk to previous prescribers when you're in a situation where there's a transition, that's great to do as well if you have that opportunity. It's not always an option, but again, you get more of the story. You can kind of see what's going on, and whether this, like in this particular case, like, oh, this is actually really concerning because we've been trying to get him off cocaine for years and he's not using it, he's doing things unsafely, versus you get a different story that sounds less concerning from a PCP who knows him, but wasn't an option in this case. But I think also the PCP didn't want to like just kind of keep inertia going here and kind of ignore it either. Like, oh, I'll just keep prescribing and the PCP will be back in a couple months. I think the PCP also, you know, understood like this is going to add additional work to me, but this is important. I want to make sure the patient's safe too. So it wasn't just like, we'll just keep things going and, you know, punt it down the road as well. All right. Other thoughts that people have on this case? Anything else?
I just wanted to mention that I think it's really important when you're making the decision about how much rope to allow this patient to have, whether you write the prescription, how many, whether you change the dose, when are you going to get him back? It's a hard decision to decide how safe that person is and how much space you should give them. One of the key factors that helps me make that decision is how much the patient is actually agreeing with me and copying to the issue and engaging with me. So if I get the story back, oh, doc, I don't know what this is all about, blah, 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 that's very scary to me. But if I get something like, oh, doc, it was just a one-off, but I really don't want to do that. And, that's not going to happen again. I've been really trying on it. And, this is the right thing to do. And if you get a sense that genuinely the patient is trying to do the right thing, that changes the equation for me, as opposed to the former case where you're pulling teeth. And so I think that's not a minor thing. And I think a lot of us will use that. And let's just not forget that the patient's willingness to engage around that honestly is a major factor in terms of whether you think it's safe or not to go forward. And that's just clinical judgment that we all have and we all need to trust. So.
All right, let's move on to the third case. So this case is another legacy patient. This patient is 72, and the PCP has been the PCP for years and knows the patient very well. So just a different kind of scenario than the other two cases. But a call to MCSTAP, a 72-year-old male with chronic pain everywhere, essentially multiple joints, knee, back, shoulder, you name it, okay? And had been on opioid therapy for 20 years, many years, maybe even longer than that. And the patient says that they have pain, it's not well controlled, and not unexpectedly, as we know, osteoarthritis progresses over years, things are getting worse. The PCP who's calling is worried about progressive medical diseases, which we'll see laid out on the next slide, frailty, fall risks, slow decline in health, been on opioids for years, tolerated them, but as starting to see kind of mild multi-system failure, these becoming more potentially more sensitive to opioids. Cognitive function is generally intact, but family is involved, and the family is concerned. Like, doc, figure this out. How can you help my patient? And I would say that my take on the dynamics between the PCP and the family is that they had a pretty good relationship. They were, generally on the same page, but at the same time, they were saying this patient needs some help. Patient had been taking the oxycodone for years. However, there was a couple early refills, running out early just for uncontrolled pain. And the PCP called MCSTAP saying, like, what do I do about this situation? And also asked at the same time, is buprenorphine an option for this particular patient? Okay, so few past medical histories. Notably, I would say COPD, which was, I think moderate, not on home oxygen, but also I'd say moderately symptomatic. Been on oxycodone for years, currently 45 mMe, some acetaminophen. Patient lives alone, doses his medications himself, although has family involved. Former smoker, drinking alcohol as well. Maybe 12 beers a week, give or take, is what was reported, with no other drug misuse, as best we could tell. Okay. And kind of as I was talking to the provider, actually I talked to the provider a couple different times about this patient. In my mind, I started summarize the competing priorities, concerns for this patient and for this doc. Okay. So from the patient's perspective, pain's uncontrolled, no one's helping me, dosing isn't enough, I need more, my life isn't going very well, and my family's in on all this, right? From the physician, of course, I only heard it from the physician side, concerned about safety, right? Falling down, drinking alcohol, taking opioids, getting older. But at the same time, realizing how do I treat this patient's pain? Like, I have limited options, right? Their concern was that dosing actually may be too high. The patient thought it was too low. And then really seeing a patient with progressive musculoskeletal osteoarthritis really suffering, walking in, hunched over, limping, etc. No surgical options here with the advanced medical disease. No one's going to, best I could tell, no one's going to replace a knee on this patient. And they were just worried about kind of doing harm to the patient by either continuing the opioids or or even stopping the opioids. It was just like harm all over. And then that pressure from the family was there too. And I think in a generally again, a positive way, but also when you add, more people like trying to get you to kind of fix something, it definitely puts the pressure on. So those are kind of the competing priorities, concerns. And if people have thoughts about this or not, patient providers who are kind of treating patients as they're getting older, I think the one thing that was reassuring with this case to me when I spoke to the PCP is that the PCP was very much engaged with the patient. Like there was trust there. They'd been, caring for many years, which made a difference, I think. So of course you can always continue to build relationships and trust, but I think that element was there, which I think was maybe times more than half the battle when it comes to these things. So any thoughts on this case as to what to do? A couple questions for us, how to think about this, because these are the questions that came up in those few calls I had. Yeah, Dr. Lennox.
I'm wondering about the social services aspect of this patient's life and the psychological, emotional aspects of it, whether or not there's any geriatrician input in his care from the medical points of view, just a whole few sets of things, that may have been looked at in the past and may be there in the record, but are probably really big factors in what the answer is to what to do with this oxycodone dose.
Well, I will say this actually was a very competent geriatrician calling me, actually. So this was a geriatrician calling. So, but definitely had, I think there was some home support. I think there was a VNA involved. But there was, I think part of the complexity that they were struggling with when they called was the fact that, of course, the patient is living by themselves, drinking some alcohol, but also on the opioids. So there was kind of concerns about that. And I think the patient was one continued independence. And, I don't think the quick answer was for the patient to move in with the family so the family could now start dosing the medicines or anything getting towards that path. But it was just a variable that was out there, right? Where even continue, even holding the course has risks too, right? As well. But beyond that, sorry, I don't know all the dynamics. Other than that, I would say that that some of that was thoughtfully considered as part of this. Well, but that's a good point. How in these situations, as a PCP calling in or managing these things, look for help, get help from other resources, whether it is VNA coming in or geriatric consultation or some other layer of support for this, because it's hard to these are complex patients as well.
Well, that being said, then the safety issue becomes the primary concern here because of the alcohol and the opiates and the other risks that are existing for this person.
Right. So the one question would be what are the we could always taper, right? We could always cut down on the find a lower, safer dose of the opioids. Patient didn't want to do that. I think I think the family recognized the safety concerns, but they also didn't want to have their father. It was kids that were involved, not kids, but children, whatever, their children involved here. So and that made it a little bit tricky, right? One thing that did come up was the use of buprenorphine, for pain. That kind of came up as an option, and the thought process there was, maybe buprenorphine's safer. It's got a ceiling effect, right? Less risk of overdose, and and that was something that we discussed using buprenorphine. the transition from a short acting or full agonist opioid, even I think this patient was like on 45 mmes of oxycodone, switching over to buprenorphine, it can be done, but many times patients aren't getting the equivalent kind of pain control. The other thing to keep in mind, it's still an opioid, right? It's still not it still has all the risks of opioids, right? It's sedating, it causes constipation, it can be mind altering, it can make, delirium worse. So if there's any, or kind of cognitive issues, so it's not without risk. So we discussed that kind of thoughtfully about making a transition. And of course, there's patient engagement too, right? The patient has to be on the same page, right? They've been on this oxycodone, although from their perspective it's not working. They've also been on it for 20 years, right? And then kind of from that like psychological aspect of being willing to switch to something else, they have to be engaged in that. Otherwise, I think it'd be unusual for someone to be pleasantly surprised that this new medication works if they went into it thinking this is never going to work. And, so having that kind of approach would be like having patient engagement as well. Other thoughts? I just have a couple more minutes here.
The only thought I had about this case, what makes it somewhat easier is the fact that the family is supportive and is engaged. When you have patients that are in similar situations but do not have supportive families, or are families that are so dysfunctional that they can't actually help, it makes it much more difficult. And then the equation of the safety becomes even more important, and so it's even more difficult situation. Luckily, in this case, that you had those resources available, but it can be more difficult.
Right. So this patient, what ended up happening with this patient is they actually switched over to buprenorphine. I believe they actually used a transdermal formulation of buprenorphine. So kind of started a buprenorphine patch and then kind of cut down on the oxycodone and then kind of went up on the buprenorphine patch. I think what, the patient did, because I was able to kind of connect a couple different times with the caller on this patient, I think the patient ultimately, didn't get, it wasn't magical, let's put it that way. I think what ended up happening kind of down the line is the patient maxed out on their buprenorphine patch dose, got up to 20 mics, and then I think they might even give the patient a little bit higher dose, like might have been like a 30, like 2 patches, I think, and then patient kind of later required maybe some additional oxycodone. And that's kind of the last I heard. So again, made a switch to buprenorphine for kind of safety reasons, and maybe actually some more, because buprenorphine is more of a long-acting opioid as well. So it's a switch from a long to short. Short to a long-acting opioid, which can be effective in some patients, but hopefully with a safer profile. But it wasn't 100% smooth, as you can imagine, right? That disease knee didn't get better, right? That bad back didn't get better. So it was a little bumpy, I think, for the patient. And that's kind of last I heard about the patient. So, but to kind of like summarizing, kind of coming back to this particular, patient, is that an intervention was done in the spirit of safety, but also done with both the patient willing to try to make the change and then the family kind of helping as well. Yes, we have a question, I think, coming up here.
Yeah, so I just wondered about whether you'd consider methadone and whether an SNRI might be potentially considered here too.
Okay, so I would say at least from using non-opioid modality, I think is always an option. I think this patient was not on any, I don't think. So that's always an option to kind of complement both any underlying behavioral health concerns, but also like from a chronic pain management perspective. Using like when I think about using methadone, I mean, methadone has its own unique characteristics, but I think the question would be, before even getting to methadone, would be, the way I think about it would be, this patient's on a short-acting opioid. Is there any benefits to going to a long-acting opioid? And if so, which one? Buprenorphine, like buprenorphine formulation, a long-acting like oxycodone, OxyContin kind of formulation, fentanyl patch, MS-Contin, methadone, right? So I think that was like the first, like that's my first branching point, right? And I think in general, for most, for majority of patients, if you can go from a short to long-acting opioid, you're almost, hopefully you'll get better kind of, control than the short-acting opioids if possible. The use of methadone in this particular patient was a little bit concerned with the safety because one, like how that patient's actually going to tolerate it, right? Use of methadone. I mean, the patient clearly was not opioid naive, which is you never start methadone in that case. But with their advancing kind of other illnesses, COPD, I think you'd always, even being judiciously dosing it, I think there was concern that you would potentially inadvertently overdose the patient. Always that concern. So, I would consider maybe methadone as maybe if you were to go down the pathway of a long-acting opioid in a patient with a lot of comorbidities, to definitely not be the first option. They would just see how they tolerate long-acting opioids in general, and then if there are particular, option for methadone you thought might get some additional benefit, maybe they have an element of neuropathic pain or something that other agents weren't covering, then you could consider adding methadone. But just with the safety profile, we did not kind of consider it in this patient.
I put my 2 cents in. I use methadone for patients with chronic pain like this, and it's the way I would approach it is just like Jason said. First, I'd make a decision about whether a long-acting opioid is appropriate and necessary, and then I would evaluate. And then at that point, his point around neuropathic pain, that methadone is supposedly a little bit better with that. That's also a key factor. But really, it comes down to, is the patient stable and reliable? Because the main issue with methadone is with dosing, and people that possibly could get overdosed. And so it's really about whether they're reliable or not, in my mind. If you have a very stable, cooperative patient who's willing to take the meds on a regular basis and you have no concerns there, then methadone is as good a choice in my mind as any of the other long actings, and doesn't have any other special. I mean, they're all respiratory depressants, so if they're overdosed, they're a problem. But there's nothing special about it other than that. So anyway, just wanted to hear it, that some people could consider using that.
So just to summarize in the last 30 seconds here, I just have, and this will be available on the deck, but just wanted to kind of summarize some of the things we chatted about today about managing patients on chronic opioids, whether they're legacy patients or not. But importance of establishing a diagnosis, coming up with a plan. We talked about patient engagement as well, both with patients, family, discussing risk benefits, kind of that informed consent is really critical. Having a treatment plan that's flexible, using non-alternative medications that many of you brought up today. Never forget the behavioral health conditions and addressing those many times concurrently. And then reassessing the patient over time, unlike that first case where the previous PCP just refilled their oxycodone every month, right? And then having supportive, monitoring for safety is important as well. Looking for aberrant behavior, using judicious use of urine drug screens, but also not being the police when you're approaching a urine drug screen, and Narcan. And then understanding patients on chronic opioids many times is appropriate and sometimes it's not, and using your clinical judgment of whether patients can continue, increase, alter, taper, or need to be stopped for kind of some unsafe or development of use disorders are kind of all in the mix. And then just from, I guess, that first caller who's like, worried about getting in trouble, document what your thought process, so it's all kind of on paper as to what you're thinking as well. All right, so thanks everyone for our monthly webinar. Feel free to call MCSTAP. We are here for you guys as you get your complicated patients. Again, calls can be quick and easy, or we can spend as much time as you like. Thanks for attending, everyone. We'll see you all next month. Be well.